It's the PainExam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the PainExam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the PainExam app with a premium subscription or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Okay, welcome back to the PainExam Podcast. Today, I am privileged to be joined with Christopher Robinson, who I met at ACIP, and he included me in a paper he's publishing on endosomes. He's currently an anesthesia resident, and he's going to be a pain fellow at Brigham. But before we get into that, a few announcements. We have ASPN Aspen's annual meeting in Florida this July. I'll be teaching ultrasound there, and it's really an amazing meeting. For those of you who've been there, know, and those of you who have not, you've probably heard of it from your colleagues. I'm also going to be teaching ultrasound in Mexico City in August 14th to 17th, and it's my first time going there. It's going to be a lot of fun, and there's really a nice lineup of faculty. I was also invited to go to Florida SIP, Florida PM&R, and that's in September. So if you have the opportunity to register, it's going to be in Orlando. And it's my first time also. I heard that's a lot of fun. Of course, we have NISIP in November. And I cannot forget Pain Week in September, which is always an amazing conference, and it's a very unique conference. So I'll probably be at all these events. So if you happen to be there, please stop by the PainExam and Rap Academy table and say hi. And of course, I have my ultrasound training, which goes on monthly, usually in New York, but sometimes in other places like Costa Rica or Puerto Rico or somewhere cool like that. And it's board prep season. So if you're interested in preparing for the boards, just go to nrappain.org or painexam.com and register. We have the virtual pain fellowship, which includes the on-demand regenerative medicine, regional anesthesia, or interventional pain with ultrasound, and TMJ, cranial nerve lecture, as well as the missed keyword lectures. So if you don't want to join for the year, just join for the month. It's a lot cheaper. And I think you'll get a lot of value out of it, as well as CMEs. Christopher, thank you for joining me today. How you doing?
I'm doing well. Thank you for having me, Dr. Rosenblum.
Of course. Tell us a little bit about yourself before we get into it.
Yeah, so I'm an anesthesia resident at Beth Israel Deaconess Medical Center in Boston. I'll be starting a fellowship at Brigham in July. And the best description of who I am is, I'm a bona fide nerd. I eat, sleep, and breathe research. Nerd wasn't so cool in high school. I'm trying to bring it back. Like, nerd is cool. I did an MD PhD at Weill Cornell Medical School. The biggest highlight of my kind of who I am was during my PhD. I'm a stem cell biologist by training. And then during the Zika virus epidemic, we had this crazy idea of how Zika virus was being transmitted. And at the time, I was running a startup, and we had this idea of like how it was being transmitted. Everyone thought it was by mosquitoes, but there was an actual sexual transmission. And to cut the story short, we essentially discovered a drug to treat Zika virus in 4 months. And then we submitted it to Nature. What was important about that is the only way that a study of that magnitude was able to be performed was through collaboration. And it was an amazing time. Wow. We got scooped, unfortunately, but then we reworked the paper. We collaborated with the lab. One of the authors later won the Nobel Prize. I would like to say for my work, but
wow.
He was already kind of on that. Yeah, his name is Charles
crazy.
Rice. He won in 2020, so I knew him before he got it. So yeah, I'm a nerd, and I love it. I love research. That's kind of who I am.
That's amazing work. I still thought Zika was transmitted by mosquitoes. I guess I'm really out of it when it comes to that sort of thing.
No, so it does. It is transmitted mainly through mosquitoes, but there is a sexual transmission where the male is a transmitter. And what's interesting is that the male can harbor not only Zika virus, but other viruses for months and months and months. It's kind of like immunoprotective environment within testes, like the sort of like the blood-brain barrier.
Okay.
Yeah.
Wow. So, okay, so you're now applying for, so you took time off before residency to do all this research, or you're doing it while you're in residency? When did you have time to do all this?
So I guess my current research exploits have been in residency. So in residency, we find ourselves in the situation that, you need research for fellowship. Some people just like to do it, but you're very limited in time.
Right.
And so the reason why I brought up my PhD paper was because, because you're so limited in time, you're so limited in skills, you're kind of in this position where you're like, well, how do I get anything done? So our current research team that we have, which is called the B team, we do research together, and it's a real true model of kind of collaboration, where we utilize the asterisks that we don't see too often in papers. It's kind of the co-author model. So what we do is that we take interested, eager individuals, whether they have research experience or not, and we divide the tasks of the project, the manuscript, and we credit everyone appropriately. And when we credit everyone appropriately, people are motivated to write, they feel included, and then we get the paper done or the projects done so much faster. So then the original problem that we had of, oh, I don't have enough time. Well, now the small amounts of time you have, you're able to complete something and be a co-author in the paper. So that's been our model throughout residency, is that we share, collaborate, and this collaboration model has resulted in enormous productivity. For example, from about September to March, our team, which now become global, we got about 60 abstracts accepted to conferences, and many members of our team have won awards. And a result from those abstracts is, I think we've gotten 20, 25 papers published this past year, and have like 10 more accepted, about 15 more in submission. So this model has just blossomed, and it became something much more than what I thought. So I think that was a long-winded answer to how do I have time in residency, and it's more that we all have some time, and we just utilize it appropriately within
Right.
our team.
That's amazing. I mean, you included me in an endosome paper that's coming out. When is it coming out, by the way?
So we don't have a date yet. We're still to receive our proofs. The paper, Exosomes, I know you're kind of an expert on regenerative medicine. Exosomes is this new, early, very hot topic in regenerative medicine, which is essentially every cell sort of, releases these small nano/micro-sized particles to communicate with their cells, but they also contain these anti-inflammatory pro-growth factors that can be utilized for the regeneration of cartilage, the decrease in inflammation. So it's this exciting. Hopefully, it turns out to be something great. Regardless, it's the topic that I find very interesting as a nerd.
Well, I truly believe endosomes are the future of regenerative medicine, because they're what makes everything work. I mean, the PRP secretes them, the stem cells, or the mesenchymal stromal cells secrete them. So that's how these cells do their thing, as far as my understanding goes. And the funny thing is, I guess I was first introduced to endosomes when I heard about, randomly, internists who just, I guess, gave up internal medicine, and they decided to be cowboys and get into regenerative medicine. They were coming to my courses, and they're like doing spinals of exosomes, and I'm like, I don't think you should be doing that. I don't. That's not, and this is like 5, 6, 7, 10 years ago. I don't even remember when I met these people, but back then it was something that I wasn't really too keen on. And even now, so with, the FDA is not really happy about people doing these procedures, but I still think it's the future.
Yeah, I mean, they come from your own body. There's the exosomes, they're budding off your own plasma membrane. So there's,
Well, what if
your body's not.
I guess the question is, right? Of course, if they're from your own body, they're probably safer, but commercially available endosomes? Like, what is the risk?
Yeah, I mean the risk is significant. Is there a standardized procedure for sterile extraction, and then refinement of them? I would say until there are better studies done, the process is standardized and we get approval. I would proceed with caution, but it's definitely an area that could provide significant potential to our field of chronic pain, which we're very limited in what we have.
Sure. I mean, I think we I think we're still scratching the surface on pain.
100%.
I just did I don't know if you caught my last episode, but Dr. Lutz wrote an article on the role of leukocyte-rich PRP in degenerative disc disease, and went over the possibility that, or the evidence that degenerative disc disease can be partially an infectious process. And so there's really a lot of new ideas and ways, and it keeps changing. That's why I love the specialty. And speaking of which, we have a change in the tide of fellowship applications ever since the anesthesia job market became so, I guess, good for anesthesia residents, maybe bad for everyone else, but I mean, or good for anesthesiologists, I should say. But you want to tell me a little bit of your experience with the shift in fellowship spots?
Yeah, I think you hit it right on the nail. With COVID resulting in a backlog of surgeries, there's been this demand for anesthesia services. And because the demand is so great, salaries have increased considerably. And as a result, people are, they're, for whatever reason, they're deciding to, defer fellowship. And we're seeing a change in the fellowship application pool. We're seeing less anesthesia applicants, still the bulk of it, just a fewer percentage, and we're seeing more physiatry, psychiatry, etc. And as a result, because there's fewer applicants, we're seeing a significant number of open spots across the nation. And as to what this means for the future of pain medicine, I mean, I'm kind of taking it, optimistically. I'm seeing it as we're getting a more diverse applicant pool. But is this kind of, I think it's, I don't know if we've experienced this in the history of chronic pain where we're actually in so many open spots. Is it going to result in us having to be more efficient in the fellowship process? Who knows, and as a result of these open spots, we have so many new therapies coming out. There's been a lot of discussion, actually a paper which I'm part of, it's called, it's the 88 pain luminaries, is we're actually discussing what should we do about the pain fellowship? Is it time that we change it? Should it become a 2-year fellowship? Or should it become an integrated pain medicine residency, like vascular surgery, plastic surgery? Is this the answer to the changing fellowship pool, or is this just another wave that it'll become popular again, or maybe it won't?
I hear a lot of people talking about an extra year of fellowship, but you're probably the first person I ever hear say to make it its own residency. And either way, I definitely think people could benefit from at least another year or two of training, especially if that program is incorporating the latest and greatest technologies. I guess the big challenge is still the latest and greatest technologies still face major coverage hurdles as well as evidence hurdles. I mean, we're not cardiology, unfortunately. We don't have 50,000 patients in a study or 10,000 patients in a study. We're lucky if we get a few hundred. And I think part of the problem is also, listen, if the patient had a fight with his spouse that morning, the pain score is probably going to be higher. There's so many other factors that can cause artifact or bias in these pain management studies. So I think, but like the field's always changing. So yes, there's so much to learn. I'm still learning, and I think it's an exciting time to go into pain management. But so I guess the answer, I guess my take is yes, extend the fellowship if you could offer more. If it's going to be the same old curriculum, or if the fellowship is not that interventional, well, I don't know if it really adds value. But if it's going to be more like a semi-surgical fellowship, the endoscopic this or sacroiliac joint fusions, more PNS permanent implants, etc., then yeah, maybe another year is not such a bad idea.
Yeah, so there's two schools of thought. There's extend. I'm a free market capitalist. If the applicant pool is changing, the market is hot for, anesthesiologists. If we extend 2 years, are we going to see a further increase in open spots? Or I'm on the school of thought where if you create a pain medicine residency that's 4 years instead of 5 years, will there actually be more interest in pain medicine? Right. So like that, and part of this, my whole collaboration model is that what if during that pain medicine residency, you rotate with everybody who's vital to us as a pain physician? We spend some time with neurosurgery because who's there for us when we do have a complication that we can't treat ourselves. So we spend some time in neurosurgery so we better understand them. We spend some time in general surgery where we learn our surgical skills, how to suture. At the same time, we spend time in, primary care, family medicine, internal medicine, where they could, because, we get a lot of patients from them. And the time where they come see us can be several years at a time. So understanding each of the different specialties and how we work with them, that's integrated into a pain medicine residency, I think would actually be beneficial for our field. And it doesn't have to be a drastic change, but just, an alternative path.
I think that's a great idea to have residents or fellows rotate with neurosurgery, orthopedics, internal medicine. One thing I definitely could say was probably missing was rotating. I want to operate and see exactly what they're doing during a laminectomy.
Yeah.
Understand. I want to scrub in with them. I want to know that stuff. So when I'm doing my minimally invasive stuff, I have greater appreciation, or maybe need to handle some sort of wound issue or whatnot, or dissect down to do a vertiflex or some other spacer device. It's not as intimidating. So I think you're right on the money. The
Yeah.
question is, if you do a residency, how many spots will be open? Are you going to have 10, 20 spots now and flood the market with pain docs? And the market is already flooded with pain docs. I mean, there'll be better trained pain docs, right? But now every orthopedic practice and their mother is hiring some doctor to do epidurals or other types of shots. And it's, you're not always getting the same quality. I mean, not everybody who does epidurals, unfortunately, did a pain fellowship or even anesthesia training.
Yeah. So I think it would be kind of a slow rollout. So if you look at vascular and plastic surgery integrated programs, it's typically a very small program initially, 1 to 2 spots. You see how it evolves over the course of several years, and it would become eventually, maybe over a decade and a half, to become this full-on residency program. Because there's individuals, who maybe they started their specialty, P&R or anesthesia or family medicine, like EM, and then realize later, hey, I think I may want to do chronic pain. So it still offers them the path to, if it's not a full pain medicine residency, they can still do a fellowship. But over time, if it's popular, maybe over a decade, maybe we just transition completely over.
Yeah, maybe. I mean, it's not a bad idea. I guess we'll see how things play out. Things are constantly evolving with pain management. So, you're about to start in September. And actually July your fellowship, correct? Another month.
Yeah, in July, I'm excited to finally be doing what I set out to do.
Well, you're already ahead of the game with the research. This paper on endosomes, I mean, you've tapped some of the top names in pain management who are involved in this paper. So you're ready. I could see you being a future leader at these conferences and really being involved and contributing to the specialty. I think it's amazing that you did that. I wish I had the drive for research. Unfortunately, research, to do it properly, you really need institutional support or at least some assistance. And unfortunately, we're not. My hospital does research, but we're not as big on research as yours, and it's tough, especially when you have a full patient load and no non-clinical time. I'm lucky I could do the podcast, but it's always nice to be able to contribute to papers like yours, even though I'm not really lifting the heavy loads like you are, but at least to be able to do my part. So I really do appreciate being included in that.
Yeah, I think it's a result of the collaborative process. Um, I think a lot of research in chronic pain does come from private practice. And kind of part of our team, which has now become global, is really about collaboration and truly taking like everyone's skills. You're a regenerative medicine expert. So, you have skills that I don't have, right? The author of the paper, Dr. William Shipman, he's another MD PhD, but he's a dermatologist. And there are skills, he's a basic scientist, and he has skills that I don't have. Versus there are, Tim Deers on our paper, Jason Young from Brigham. Everyone has their own skills, and they're all coming from all across the U.S. And so, by utilizing everyone's skills and expertise and time available, we can actually do research even though we don't have the time or resources ourselves. So that's kind of our model in our team. And we're hoping that, other groups, will adopt this such that there's no longer a limitation from a lack of resources, but it's more just a limitation of, how can I find the right team, or how can I find, people who are open to having new members? So it's just a different outlook on research and how to do so.
Yeah, I mean, as I get older, I'm realizing the value of teamwork. My whole pain exam thing was really a one-man show, and over the course of the last couple of years, I've been collaborating with other physicians like Al Abdul Saeed, Arun Kalava, and the docs who run societies like Rudy Malayil and a few others, and it's so much nicer to be able to work with great people, and you really get a lot more done, um and also new ideas, new directions. I'm trying to build up my online, more my in-person workshop courses, and to be honest, I don't want to be the only person to teach. I like it when I have other instructors and I have people who are bringing their own perspective, because everybody's coming from a different angle. And I
Yeah.
don't know everything. Nobody knows everything. So it's always nice to see how other people teach, how other people do their regenerative medicine stuff. I mean, I keep telling people there's very few things that are 100% set in stone with this stuff. I mean, this is still the wild
Yeah.
west of regenerative medicine, and it's so hard to standardize things. I mean, you even talk to people about antibiotic prophylaxis with intradiscal PRP injections, and you'll get a few different answers. So I think that's kind of what makes it interesting. I mean, if it was just like, I guess I keep saying cardiology, where it's like, you have to do X, Y, and Z. That's just the way, and there's no other options because this is what the evidence points to. It wouldn't be as exciting and fun. Here, I feel pain management and anesthesia, there are more than one way to get to your final destination, and there's
Yeah.
some sort of artistic license, right? When you're putting a patient to sleep, there's no one way to do it, and I think each way has their own, pitfalls and advantages. So you could add a little bit of your own flavor and style to it, and that kind of goes for pain management as well.
Yeah. One thing that I wanted to mention is it's very interesting that chronic pain, in particular, lower back pain. And if you attach that with migraine, which is the second leading cause of disability, there's not as much attention and focus on it. It consumes, if you adjust it for inflation, it consumes over $1 trillion in healthcare costs, economic costs, lost wages. And you're talking about these studies, and they have such few patients. It's baffling why we're struggling to get big population, like big study sample sizes, even though it's the leading cause of disability worldwide. So I hope that somewhere, somehow, people start to catch on and be like, hey, since this is such a big issue, what are we doing to solve the problem of, recruiting patients for our studies, such that they can become as big as, cardiology studies where they have hundreds of thousands of patients. Maybe pain medicine, will get there eventually, or maybe it won't. But, I think in the meantime, I think the big answer to a lot of this is collaboration. How do we get others involved, passionate about research, such that we do really good studies where the evidence is, level one, where people don't criticize our studies, where they're like, wow, this is a really well done study.
Right.
I'm going to recommend it to my patient because the patient fits the good patient selection. And I'm not just using it to be the first to insert this device or, because it's hot and trendy, but because I know the data. I know that it'll, based on prediction models, it'll work for this patient. And maybe it'll kind of rejuvenate our field such that people don't see it as this, it is a wild west because there's not much out there, but we start to be like, hey, this is solid data.
Right.
And, we know like for the new like medications for weight loss, even though they're not new, but like we can be like, hey, this treatment will be, we can predict it'll be this efficacious for this patient versus just like, oh, we'll try this, we'll try that. Data is meh.
Yeah. I think part, when it comes to the study population of pain management, you also have the whole confounding factor of opiates. So when you're looking at
Yeah.
back pain, it's like you take 100,000 patients with back pain, a large percentage will still be on opiates. Maybe they're remnants of back in the day when we just wrote it like crazy, or maybe they're just severe, or they're. Then the thing with the back is like, well, maybe every day this patient, you know, sits in a car for 3 hours, or maybe this guy is just one of those couch potatoes who just doesn't really have any motivation to do anything for himself. I mean, so I think it's still tough. It would be ideal and nice if we get that many patients in a study. And you're right, enough people suffer from these problems to really. Yeah, I guess the other thing is, well, sometimes back pain comes and goes. It's like it can be there's good days and bad days, so that might be a factor as opposed to like hypertension, which I don't know. I guess some people have good days and bad days with hypertension, but I mean, there's right. There's a lot of who knows. I mean, I don't know. I personally, I'm really a big fan of preventative medicine. I
Yeah.
think I think all these preventative things, whether it's diet, exercise, mindfulness, I think this stuff needs to be taught in elementary school, high school. I think our society is a little backwards. I don't understand. I don't know if you have kids, but I do. And I don't understand why they made us adopt iPads as opposed to pencil and paper or pen and paper in school, because iPads are just another electronic device. And then what do the kids do when they have a break from that electronic device? They go on another electronic device. And it's awful for the neck, right? It's really bad for the eyes, for the neck, for the brain, for the posture. Nobody's thinking about these things. And then even though they're still using the iPad, they still get books, and they're not thinking about, is somebody looking at the weight of the backpack of a kid? There should be restrictions on that. I mean, people don't pay attention to that stuff, but these are habits that people develop where they just misuse their bodies. So, I mean, preventive, and also, of course, diet, which is a whole nother, do a series of podcasts about that. But I think not everybody went to med school, and everybody's up on it on the data, and even doctors aren't that good about this stuff, right? We don't really all do everything properly, but I think if people are aware that just their habits, especially spending too much time on the electronics with the posturing that's involved with that, looking down at your phone or your computer, or you know not having ergonomic setups, there's a price to pay later on in life.
I agree. There should be some pain prevention program.
Yeah, standardized across the country in schools.
Maybe that's in elementary school. Maybe that's PE, physical education.
Yeah, yeah, they're right. That's just as important as learning how to shoot a basketball, maybe more.
Yeah, I mean, we send all our patients to physical therapy before we trial any injections. Imagine the economic benefit we would get. Maybe we're not gonna notice it immediately when you're young, right, in your teenage years. But imagine the benefit that we would get a couple decades later, where you're no longer in where you're. I mean, we'll probably still get pain because we're not supposed to be on two legs, but maybe you're not getting all those surgeries, or maybe, as a result of you being more physically active, you don't get all these comorbid, disorders. And maybe you live longer, maybe you have, fewer problems. all because of a pain prevention program started with Dr. Rosenblum today, implemented all across the nation, and we see the effects later. I mean, imagine the impact of just preventing pain and just even educating. If you look at medical school,
Hmm.
I'm not even sure I got a lecture on pain.
Right. Right. I think I did, but it was not, it was, listen, or even I went to med school at least 20 years ago and over 20 years ago. And back then, my training in nutrition was awful. Of course, nutrition science changed since then, but still,
Yeah.
I mean, the amount of time spent on diet and nutrition and preventive therapies, it was awful. I'm sure it's still not where it needs to be. Um, the what was I going to say? Oh yeah, the other question before we wrap it up. When patients say to me, "Doc, you tell me that regenerative medicine is probably safer than steroids, probably lasts longer than steroids, according to many of the studies. Um, why isn't it covered?" How do you? I know you're still not even a fellow, but how would you respond to that? Because I have my response. I'm just curious as to what you're going to say.
If they ask me why it's not covered, I would say that there's more research that needs to be done to standardize the process, more rigorous studies. I think regenerative medicine, there's a lot of heterogeneity in, the products that we use. And I think at some point as a field, me versus my colleagues, we need to do better, well-controlled studies, and as a result, maybe regenerative medicine will be covered. So I would tell my patients, you can also advocate for these studies. You can, depending on how you vote, and how you also, speak about, your results that result from when we use regenerative medicine on you. So I think it's not one simple answer, but it's really again kind of comes back to kind of who I am as a nerd, and it really revolves around research. We just need better research to be like, hello, payer, this should be covered because hey, we have so many patients on opioids. We use regenerative medicine, and now their opioid requirement has decreased by X%. So I think the answer is research and how we go about utilizing research to get things covered.
So that's a great answer. There's also, so not every patient who has back pain has back pain from just the facet or just the disc or
Yeah.
just the nerve root. It's often a combination of factors. And the way our system works with the payers is we're not allowed or reimbursed for doing more than one
Yeah.
on a day. And when it comes to my regenerative medicine patients, where I'm doing my work on the spine, I'm like, well, the insurance is not involved. And for the same price you're paying for the PRP in your disc, if your facet needs it or your SI joint, I'm gonna just do it. And I think, some people don't include in the price. I try to, and for certain things, not everything, but I guess the payer is not going to allow the doctor to have free reign to just do everything he thinks he needs to do that. Of course, the doctor needs to be honest, not overtreat and just, do more than necessary. But I find that, when patients are paying for the therapy themselves, I could actually take care of more than one thing at a time and save them an extra trip to the office, which I think is a real nice thing.
Yeah, I think it kind of gives you back your autonomy. And who knows, we may see a shift in the future if we keep on getting these hurdles with insurance of a more cash only pain practice. And who knows, maybe it'll actually be cheaper in the long run for the patient and healthcare system
Right.
than just doing, injection follow up. And sometimes you have to do two diagnostic blocks to receive the final therapy. That's 4 visits
Oh
before
my,
you get the action. And
yes.
patients are frustrated with that, right? They're like, I only got pain relief for, one day. And you're like, I know.
You're
And maybe you
striking a
can,
nerve here because of, yeah, I mean, it's like, all right, this is your problem. I need to do 2 diagnostic shots, 2 follow-up visits. And yeah, maybe I'll treat it in a month or two. And people are like, what? But that's how it is because they're not going to pay you without those documented visits between, and they're not going to pay for the documented visits unless it's at least a couple weeks after the procedure. It's just crazy. Um, you know, I think, in other countries, it's not it's not easier in certain ways, but with respect to this, people don't need to get dragged back and forth so many times just to get treated. So it's just one of those things that's not the most practical way of helping people.
I mean, look at the economic costs of delaying the final treatment, visit, revisit, taking off time from work if they're working. I mean, maybe there should be analysis of these new changes in, policies. Is it becoming more expensive, right? Like, are patients getting discouraged from, having to do these multiple diagnostic blocks, or is it adding efficacy? I think the only question, the only way to answer that is research.
Yeah, right. Right. On that note, I think I have to wrap it up and get my day started. I wanted to thank you, Christopher, for coming on the podcast. Look out for Christopher. He is a rising star. He is going to be probably in charge of something big in the next coming years. I can see it right now. And I'm sure he's definitely going to be at Aspen or one of these big conferences, right?
Yeah, I'll be at Aspen. I'll be giving a talk on Thursday about kind of the economics in the private practice industry.
Okay, I'll be teaching ultrasound on Thursday, but maybe I'll see you for a beer.
I'll see you there. See you in Miami.
Well, thank you for being on the show. And
thank you for inviting me.
My pleasure. And if you're studying for the boards, check out nrappain.org for the PainExam board review, as well as see us at the conferences or at any of our upcoming workshops, which you could find at nrappain.org. Just go to Pain Management on top and check out the calendar. Thank you. Good luck.
You
have
are
a great
solely
day.
responsible
Thanks,
for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.